Hello and welcome. My name's Mark Bowie. I'm Director of Palliative Medicine at St Vincent's Hospital here in Melbourne, Australia. I'm also a member of the executive of the International Collaborative for Best Care of the Dying Person. So it's my pleasurable job today to be able to welcome you to this webinar and to listen as well as learn from our two exceedingly interesting guests. So it's good that you're joining us here today or at some stage in the future listening to the recording. What we'll do is I'll just give an introduction and then we'll have our two speakers speak for about 20 minutes and then there'll be room for questions or commentary for about 15 minutes at the end. And following that, you'll have a little bit on information about work of the collaborative in the future. Just very quickly, for those of you who haven't joined a collaborative webinar before, the International Collaborative for Best Care for the Dying Person stretches across 6 continents around the globe with about 700 members. And it's something that anybody can join with an interest, obviously, not just in palliative care, but those that are dying at the end of life. There's a vision where would like to see a world where all people experience a good death as an integral part of their individual life, supported by the very best personalised care. You may or may not have touched a point with the collaborative at various areas in this sort of triangle, but at the heart of it, in a very practical way, is the 10-40 sort of continuous improvement model, which allows jurisdictions or countries or states to develop their own care plan, which has the 10 core principles and 40 KPIs as a consequence of the best care for the dying person. From that and the International Collaborative and the work it does in supporting that, it has a very active research and development arm. It also has quality assurance tools that have been developed to help people to implement and amplify the use of the care plan for the dying. And we also have a lot of learning and teaching in activities and environments, which I'll talk about at the end of the presentation today, but also that we do have, areas where there are sort of key areas where people are coordinating and helping to implement across jurisdictions and countries. Great. Well, we'll get on with things. Just to also announce that we've now become a collaboration has just been established between the International Collaborative and Best Care for the Dying Person and the new EAP Task Force for the Care of the Dying. And this has really only just come into fruition in the last few weeks. And indeed, this is the first webinar where we're jointly badging between us and the task force. So it's nice to see that we are expanding and developing and growing and bringing a new audience to the table. And again, this is to really promote a lot of the work that we're doing at international meetings, but also we're in the process of developing collaboratively a white paper on best care for the dying person with EAPC. So to the presentations at hand tonight, or tonight in Australia, but midday in the UK. Please remember, if you want to ask questions, use the chat function on the Zoom platform if you want to ask any questions, and I'll be able to see them coming up from there. So really just to introduce our first speaker, we've got the two speakers tonight. I'll just stop sharing my screen. But it's a pleasure for me to welcome one of my colleagues who I've worked very closely with over the last 10 to 12 years. But Dr. Mark Ross is the Chief Principal Investigator of the first psilocybin-assisted study for therapy in those facing end-of-life care in Australia. She's also a clinical psychologist and researcher here at St Vincent's Hospital, Melbourne. So, Marg, without further ado, I might let you take over.
Thank you. And my apologies because it is 11 p.m, so this could be interesting. I will do my best. Let me just see if I can share my screen. I do that, and then I've got this. And let me just see if I can play my slides. How's that looking?
Terrific.
Can we see it? Fabulous. Thank you. Thank you for the thumbs up. whoever gave me that. Thank you for having me. I'm going to dive straight in because there's a lot to talk about and I have very little time. So look, I'm a clinical psychologist. I work in palliative care and psychosocial cancer care on the wards, and have done for close to 12 years now, and had the pleasure of having Mark as a co-principal investigator on our study, which we've really just finished. So we've completed our clinical trial, which was a phase 2B clinical trial, looking at how we could alleviate anxiety and depression in our palliative care patients using psilocybin assisted psychotherapy. Now, psilocybin, for those of you who don't know, many of you probably do know, but psilocybin is a psychedelic compound, and it's found in a genre of mushroom called the psilocybe genre of mushrooms, otherwise known as magic mushrooms. These are obviously not given as magic mushrooms. These are, CGMP synthesized, psilocybin tablets, dose reliable and good quality. But we have just finished that study, and I have to say, to go back a little bit, one of the main reasons that I initiated that study in the first place was because, for the simple reason that working with people who are suffering from death anxiety and existential distress, the talking therapy was just not touching it. For some people, it could be quite helpful, but for many, it was really, really difficult to access the depth of that fear and that terror. And this fear was so visceral and quite primal. So even creative therapies, music therapy, art therapy, these were helpful, but difficult for us to have sustained response once those therapies had sort of finished. And unfortunately, the fear often reemerged in a small percentage of people. So medications, unfortunately, sort of flattened the symptoms and had their own kind of problems, in terms of anxiolytic. So they kind of felt quite locked in with this suffering, and it had a ripple effect, not just for the patient, but also for their families and us as the community of care. I also don't need to tell you how the psychological and spiritual distress of our patients can really exacerbate physical symptoms of their diseases as well, rendering them almost treatment refractory at times. So I was looking for emerging treatments, and I'll tell you a little of the story and the history of how psychedelics kind of found their way into medicine. It's quite an interesting and rich story. So I'm hoping that this will be somewhat interesting for you. But what I have to say is that while I was looking for something that would help this distress, what I came to realize in the process was the pivotal importance of these spiritually enriching and transcendent experiences that people were reporting after these treatments. So I want to talk a little bit about how psychedelics, and in particular psilocybin, may alleviate both anxiety and existential distress, and the central role of spirituality in this treatment. But first, let me tell you a story about how the academic world began intersecting, I guess, with the spiritual or the transcendent. So this is a picture of Marsh Chapel. Some of you may know this. This is the Good Friday experiment. So in Harvard School of Divinity in 1962, a very interesting experiment took place. You probably all know who Timothy Leary is. At the time, he was a professor of psychology at Harvard, and he started the Harvard Psilocybin Project. So he was very interested in looking at states of consciousness and spirituality and so forth. And he was not only professionally interested in psychedelics, he was dabbling in way too much from a personal perspective as well, which ended up seeing him fired. But what happened was Timothy devised a research experiment in 1962 that really grabbed headlines, and I guess for the first time really brought religious or mystical or spiritual experience to the science arena in that dialogue. So 1962, Timothy Leary and his PhD student, Walter Pankey, set up a small randomized control trial where they gave 20 volunteers either psilocybin, which is this psychedelic compound that produces quite profound psychedelic experiences, or niacin, which kind of provokes, a little flushing or tingling kind of a feeling. And for people who have never had a psychedelic before, they don't quite know what they've got. But not only that, they conducted this in that chapel that you can see on your screen on Good Friday, during a sermon that was delivered by a gentleman by the name of Howard Thurman, who was Martin Luther King's mentor. So he was an exquisite orator, and he delivered these extraordinary sermons. So what happened, you might ask? Well, it's gone down in history as being the miracle at Marsh Chapel, otherwise known as this Good Friday experiment. Those who had the psilocybin reported these very powerful religious experiences, sometimes very challenging as well, but nonetheless exceptionally powerful. And the takeaway was that sort of in the right set and setting, people who had the psilocybin had really profound spiritual experiences that changed their lives. And indeed, the follow-up of the survivors some 25 years later found that they considered this experience among the top 5 most meaningful spiritual experiences of their lives, up there with getting married, having children. So, you know, this was quite an interesting discovery. It all of a sudden, you know, enabled us to see that you could actually evoke a spiritual experience using a compound. And another pivotal story, albeit an accidental finding, was something that also took place in the 1960s. There was a gentleman by the name of Eric Cast, who was an anaesthetist, and he was looking for a pain analgesic for his cancer patients. And he was particularly interested in LSD, which is chemically quite similar to psilocybin with some key differences. He was very interested in its pain-altering potential. So what he wanted to do was he did some research with it, and unfortunately, often on patients who had not consented. So this was the 60s, folks. People could just give you a whopping dose of LSD without telling you, or in the name of research. So now the study findings were interesting. It could, you know, there was some alteration of pain experience, but the unintended side effect, which was really important here, was that they found that LSD quite dramatically and rapidly eased people's fear of death and their anxiety around the dying process. They were also reporting really quite profound spiritual experiences, you know, feelings of sort of oceanic boundlessness, cohesion, sense of community and camaraderie amongst their, you know, their fellow patients. And so he stumbled across something very important that led the cancer research to kind of take off and run with that. So this is really significant because the spiritual or the mystical was consigned to religious talk. It was not in any way scientific. Research wasn't interested in it. But they started to realize, well, maybe this has a place here. Maybe we could occasion spiritual or mystical type experiences in the right setting with these compounds. So this, and not only were they quite spiritual experiences, but and quite profound for people, but they started having commonalities that people were reporting, which then led to the fact that a number of researchers, Stace Pankey Richards, you know, armed with these findings and these initial reports of these kind of spiritual experiences, was that they developed a mystical experience questionnaire. They wanted to try and give it some scientific grounding and some scientific, like a belonging in the scientific community. So these mystical experiences, they identified that there were subdimensions in the commonalities that people were talking about. So sometimes ego dissolution that people experienced, or complete ego death, transcendence of time and space. Time seemed to collapse. So things like, you know, experiencing themselves in the future or in the past, in the present, seem to all collapse and be accessible to people during these experiences. Quite positive mood, sense of unity, and an increased sense of connection. And these mystical experiences, very interesting finding here, appeared to have a relationship for people having better therapeutic outcomes. So they were seeing people who were having, you know, psilocybin in their therapy treatment. And if they were having mystical type experiences, not everyone would. They were sometimes present, not always present in psilocybin. But if you were having sort of more profound spiritual experiences, these were leading to better outcomes, more enduring change in behavior, and changes in perspective for positive. So, and this is the finding that's been pretty consistently found in the psychedelic research, and particularly that's been spearheaded in Johns Hopkins. So this gained traction as to how the mystical could be used therapeutically, and particularly for cancer patients in the 60s. Although, important to note, we were pretty late here in terms of the spiritual aspects of these compounds being already known by ancient and indigenous societies, where these spiritual, aspects and the psychedelic compounds found in plant medicines and fungi, these indigenous societies who were using these compounds in sacramental contexts, they knew that spiritual experience was beneficial here. And the spiritual aspects of these experiences held and continue to hold a profound significance in their cultural context. These were seen as sort of connecting with divinity or ancestors, visiting spirit world, gaining insight and bringing healing. So we were pretty late to the arena, I have to say, in medicine. But the use in indigenous society, with shaman, often highly ritualized, the spiritual significance of the act was regarded as extremely important and only used with a trained medicine man or medicine woman, only in very specific contexts. And inappropriate use was very frowned upon. So there was a deep reverence and respect for these compounds that would evoke quite profound spiritual and altered states. So they were often marked transition in their lives and were conducted for healing and considered very sacred. But yes, but unfortunately, the medical researchers in the 60s were not the only ones interested in psychedelics. So the counterculture movement also were quite interested in psychedelics and took quite a shine to the mind-altering and the mystical aspects of these compounds, which drew attention to the Nixon administration in the US, who were quite grieved with the anti-war left and wanted to shut down the hippies protesting his policies, and particularly the Vietnam War. So a pretty swift political backlash ensued. And unfortunately, these compounds were rescheduled, and the Controlled Substances Act of 1970 pretty much brought all of the research to a grinding halt for about 2 decades. And then the rest of the world quickly followed suit, with psychedelic use being a criminal act. And unfortunately, they were classified as being harmful substances with no therapeutic value, which was simply not true. That was not what the science was actually saying to us at that stage. And particularly for anxiety for people who had cancer, particularly advanced cancers. And this is, it was showing that, there was quite profound changes going on for people who were taking psilocybin and LSD. So that was about it for about 2 decades. And then the research resumed. And with it, much more robust methodologies. We did actually inform people that we were going to be giving them a psychedelic. And the findings were really quite remarkable. So these are some of the more seminal psilocybin-assisted psychotherapy studies. There was another one by Peter Gasser in Basel. He used LSD, though, and that was with palliative patients. But these 3 are the more seminal kind of findings in this arena. And particularly the last 2, the ones by Griffiths et al. And Ross et al. In 2016, they found between 70 to 80% of their samples, small samples, but 70 to 80% of them experienced remission of depression and anxiety. And this was sustained at 6 months. And this was with a single kind of therapeutic dose day, supported by psychotherapy either side. It's important to say that happened. But from a psychiatric point of view, that's pretty remarkable, and we don't really see results like that, I have to say. So that certainly grabbed my attention as a therapist working in this space, because we were really, for the ones who were not responding to our usual modes of treatment, which was the talking therapy or medication, there was not a lot more that we could really offer them in terms of being able to alleviate their distress. So this was, I guess, one of the key reasons as to why I was keen to bring that to Australia and to palliative care. The other thing that I was really mindful of is that this was just being targeted for cancer patients, but in the palliative care ward, I was seeing people with non-malignant disease who were just as distressed sometimes more so because of the uncertain nature, the trajectory of their illness. So that often brought even more anxiety in some ways. So, but you may be wondering, how does it actually work? And unfortunately, I don't have a lot of time to go into huge amounts of details with the psilocybin-assisted therapy. But essentially, this is a combination treatment, and it's important to say that because I think with all the hype of psychedelic research at the moment, people are thinking that it's just a drug, that you just give them the drug and then that's it, it will evoke all that. That's not the case. This is very heavily supported by thorough screening, because it's not for everyone, a period of preparation, and also a lot of integration so that they can make sense of their experiences that come along with them. So there's really kind of 3 phases to the treatment. There's preparation. You're often with 2 therapists. There are protocols now that are shifting away from that, but there are 2 therapists with the patient. They lead them through a process of understanding how to navigate that experience, bringing an intention into their experience. And then the dose day, where the psilocybin is administered, goes for several hours. They are given headphones, eye shades to help augment an internal focus. And then 2 therapists stay with them the whole time and help them kind of move through this experience in a way that's very hands-off, but they're there in case they need support moving through that. And then we just allow the psilocybin to help elicit these kind of very deeply personal experiences. And the thing that is quite interesting about psilocybin is that it fairly reliably evokes intense personal introspection. And so this is why it's it's got this quite remarkable therapeutic potential. But on top of that, this is where what makes the therapy work more effectively is where it gets really, really interesting. So there's a number of there's multifocal kind of treatment targets. There's a number of different languages, I have to say, in terms of how we can describe why this might be more effective. There is the neuroscience, there is the psychological, there's the spiritual, there's the shamanic kind of understandings of why this is useful. Let me start with the fact that it is a serotonergic compound. And the psilocybin itself affects brain function by binding to serotonin receptors, particularly 5-HT2A receptors, which are involved in a whole range of cognitive and perceptual processes, which is why we have such big perceptual changes. If you were to ingest psilocybin, and it produces experiences like really augmented sensory experiences, synesthesia experiences. You experience music in a very augmented way. Often people talk about feeling like they are music or seeing music and so forth. And you experience quite vivid, open or closed eye visuals that are quite vivid. Also tends to downregulate the default mode network, which is this region of brain circuitry that is involved in self-referential thinking. When you're sort of at rest and you're thinking about yourself in the future or in the past, that's when your default mode network is activated. And what we know is that in depression and anxiety, your default mode network thinking is quite ruminative and quite negative and quite rigid. It's difficult to shift. So it's thought that the psilocybin works by kind of reducing the activity in the default mode network by downregulating it, which then allows access to sort of more expanded perspectives, expanded sort of ways of thinking, depth, and an increase in the sense of interconnectedness towards others. So there's also a sense of, I guess, the open heart kind of experience of psychedelics, where you have a sense of increased sense of connection to others, increased sense of connection to the natural world. So these are, and also ego dissolution. Often people will talk about the idea of, having an experience of kind of dying before you die. So people can experience their death in the symbolic and have an experience of letting go, feeling that they're connected to something much bigger than themselves. So, and these spiritual and mystical type experiences that people talk about, which we'll talk a little bit more about in a moment by telling you what some of the experiences were of our patients. So,
Marg, sorry to disturb you. You've got about 2 minutes, 2 to 3 minutes
2 minutes,
left.
that's okay.
So,
I've got about 2 more slides next. I'm good.
thank
I
you.
can't believe I'm on time. This is about the first time, especially at 11 o'clock at night. I think, despite the best attempts by, our researchers like Roland Griffiths and co, who have kind of developed these instruments like the mystical experiences scale, have done their best to try and capture, what's happening and deliver it in a way that the academic arena will take seriously. We still have a problem. And that is that science tends to favor, strictly psychological and neurological outcomes. Yes, we want reductions in symptomatology, lower depression, lower anxiety, nothing wrong with that. We all want that. But here's what's happening, and it happened to the previous studies and it happened to us, and that is our participants are reporting deeply spiritual experiences, profound experiences that are difficult to articulate. They're very difficult to capture. They're often highly symbolic, very transformative, and usually rest way outside of our usual therapeutic reach and our comfort zone as therapists, I have to say. To give you some examples, and I can tell you I was in no way prepared for the depth and the profundity of some of these experiences that our patients reported to us, which was, experiences like, dancing with a deceased relative, with a deceased partner, meeting their unborn grandchild, being propelled into the cosmos and watching themselves being reborn again and again and again and again, experiencing a sense of oneness and with all of humanity, and feeling comforted by the idea that death is just part of life and I'm part of this big cycle of life and death, and it's okay somehow. It's sort of transcended the idea of it being terrifying, and actually it's part of it and it's okay. That there's an ability to let go of the body and their lives, resolution of old conflict, and softening into fractured relationships with forgiveness. So experiencing their own death where they felt like their memories were kind of dissolving in front of them. How do we capture this in questionnaires? This is very difficult. Or, feeling like they had a profound experience with an entity or a teacher that felt very calming. Or, they experienced another realm, as they like to describe it. So, a sense that life goes on and it's not so terrifying. So, and also awe that, for the vastness of their experience. So, it's really difficult to capture this in research, and as a researcher, that's something that I'm going to really struggle with, and to the point where one of our patients actually turned to us and said, Mark, how are you going to write this up? After telling us that she'd had this, extraordinary experience, very difficult to put words to. So, and the difficulty is our science has very specific outcomes and language towards the pathological and the neurological and the scientific, but we don't have language for the profundity of these spiritual experiences. Anyway, that's my conundrum. I digress. But
Mark, I might just need to get you to wrap up. Sorry.
I'm going to finish up now. So I think, we know now, the previous studies have talked about the fact that, the mystical experience in these treatments really, aside from the fact that they can be deeply transformative, are associated with more enduring change, enhanced spiritual well-being. It tends to decrease desire for hastened death, decreases demoralization. So, and it does increase a sense of connectedness, but also kind of helps people transcend fear around dying. So the last slide, which is, I'll be very, very quick, I promise. I think one of the things that I'm mindful of as well, having seen this from the beginning and all the way through to the end, is that we may be returning to, I think, a very important form of spiritual treatment and giving it importance again in this, particularly in this arena at the end of life, which has been kind of disregarded over time. But I'll close with a very quick story. There's the story of the ancient medicine technique that was practiced in the temple of Asclepius in ancient Rome. So in the time of ancient Rome, when people were in need of healing, they would go to the temple of Asclepius, who was the god of medicine, and they would be attended to by the various herbs and treatments and the doctors of the day. And then they would sleep in the temple and they would stay there in order to dream and have, dreams where they may have an idea in their dream, or they may have an insight, or their dream may give them direction, or give them some kind of strength or comfort during their illness. And in the dream state, they were able to access transcendent and access spiritual depths. And these states were considered a very potent medicine. And the Indigenous have often said that we have become disconnected from our spiritual lives and fallen into a great forgetting. And I guess my hope is that in our work, we will some way, move us towards a remembering and our reconnection to our spiritual landscape that won't just enliven our life, but also help us to die. It's certainly something we've witnessed and had the privilege of witnessing in our trial, and I hope that continues. So that's it from me, and I'm sorry I went over time, Correct?
No, thank you, Marg. And look, I know it's it's a fascinating area of care, and we could listen and talk, but there will hopefully be some time for questions towards the end as well. I might just get you to stop sharing your screen, and I will.
Let me get off there. Stop share. There we go.
Thank you, and importantly invite Perrette, Professor Perrette Paul, who is the head of the Institute of Palliative Care based in Salzburg at the Paracelsus Medical University in Salzburg. And her biography is in the details of the talk today. But just to say that she is just joined us on the executive of the Best Care for the Dying Person, and is also chair of the EAPC Educational Reference Group, so the connection into EAPC. So thank you, Perrette. I think screen is sharing. Thanks.
Yes, thank you so much. It's really fascinating that we have psychotherapists speaking about existential care in the sense of what medicine has been missing out, and now me, anthropologist, speaking about medical and nursing education and how to bring this topic back into caregiving. So, I think Margaret provided quite many keywords that link to my presentation. So I have been in palliative care already for 13 years, which is not very long, but this kind of human aspect and meeting patients as a human being before being a professional in something has been one of my hidden agendas, and all my studies in spiritual care is my mistress, I call it. So I've never received any big funding for that or had any leverage to really study it as I would like to. But before, I always have had this kind of question in my mind that there are lots of interventions for spiritual care, and people who have suggested those interventions have withdrawn those later again, and somehow they don't seem to function. And so that's why I want to talk to you today about the importance of self-assessment in spiritual care. So before we introduce any interventions to our students, colleagues, and so on, the part of self-assessment seems to be essential. And I have brought with me a case study as well that has taught me a lot about this as well, and about myself as well. So what is spirituality? We just conducted in Austria a study with my nursing students and asked them just to define what spirituality is. And interestingly, many of say that it's something that means different things for different people. It may be religion that helps them understand certain situations. For others, the meaningfulness comes from other aspects, such as trusting one's own strength. Spirituality means living as a whole human being, being seen as an individual and seeing others in their whole complexity, but also as a conscious and open encounter with nature, people, things, and myself. And for some others also that it's not a religion or religious community, but an individual experience of pleasant as well as difficult situations or times. So these are the students who work in the practice. That's their perception of spirituality in our region. This is published. You can have a look. Always when something is published, I put the reference directly to the slide. Then we have the EAPC definition of spirituality, which is a dynamic dimension of human life that relates to ways person, individual, and community experience, express, and seek meaning, purpose, and transcendence, and the way they connect to the moment, to self, to others, to nature, to the significant and or the sacred. And it consists of existential challenges, value-based considerations and attitudes, as well as religious considerations and foundations. And this is also, I have to say, is a working definition, but it has been used quite widely in Europe, and so maybe so far, as long as we don't have a better definition, this is quite good as a working definition because it's quite broad. And in some discussions, there has come up also the question that some regions tend to use the existential, others think of spirituality as solely religious experience. But there is the EAPC white paper about spirituality, and we urge to use the term spirituality to remain consistent with the WHO definition of palliative care. So, oh, and about the picture that you just saw, this was created by KI. I put the spiritual care definition into it, and that's what came out, this kind of, I think I have to go back now for it. So this mess came out of it, and you see it's kind of beautiful, but it has lots of moments in it. So that's how our spirituality definition looks like, interpreted via being image creator. Then in Austria and in Germany, we have launched a little group, which we call ourselves Neurospirit Group. And my students have been leading two quite interesting studies, one conducted in Austria and other conducted in Bavaria in Germany, about spiritual distress and how healthcare professionals meet the spiritual distress on neuro-oncological and neurosurgical units. And we use this kind of vignette-based method, which has been published as a method paper already. So have a look at it. We validated the vignette and asked then healthcare professionals' reactions towards this and how they would act, what would be their first thoughts and reactions on that. And as you might know, in palliative care wards, people maybe have heard the word spirituality more often, and there might be also more time and space to attend the spiritual dimension of patients. But neuro-oncological units contain also many people who are dying, who are facing their end of life, and would definitely benefit from spiritual care as well. So that's why I find this quite interesting. And I just report about the Bavarian study because we had both physicians and nurses recruited, approximately 50-50. They had quite a lot of working experience already. There was 1/3 were male participants and 2/3 female. Altogether, we enrolled 143 patients. And what about their own spirituality? In terms of self-reported spirituality and religiosity, participants predominantly describe themselves as somewhat or a little religious or spiritual, with minority reporting that they did not feel spiritual or religious at all. Only 8 individuals described themselves as very spiritual and only 4 as very religious. So I have noticed during the past years that it's really difficult to talk about spirituality because exactly this point that people say, I am not spiritual. So, and that's where it stops. And so the question is how to overcome this. But what we heard from those professionals is also, I think, kind of a matter of great concern. So first of all, empathy is a trait that is hard to learn. So people have this kind of feeling that you either are born with a certain amount of empathy, but it is not something that you can like teach other people how to be more empathetic. Then, of course, yes, it is important to clearly show to this patient that she's not left alone. And there are other medical specialties working closely together so to help her. So, but, you know, so we will make a referral to a psycho-oncologist or a pastoral caregiver or spiritual counselor. But still, it is, and this they say that interdisciplinary approach is really important, but they don't see themselves then as the spiritual caregivers, or it's not their role, it's other people. Yes, then again, also the lack of time when you sit with the patient, but you are constantly called off. The buzzer is calling, phone is calling, and you just don't have time to sit with the patient and be there. Then this comes with time. You think, okay, you know, it could happen with me. It could happen with my loved ones. When you get older, this concern is getting even bigger and bigger. It's growing. Others say also that you get desensitized by your work. You realize that when instead of empathizing with caring relatives, you are annoyed by them. Yes, then there is a feeling that you need also education, how to react in a right way, and how to find mental relief, because you are under much pressure on the stations, obviously. Then also physicians say, yes, I keep the conversation at the clinical level, so I talk about bodily functions and things that are charted, but not about the spiritual things. And people also say that when I saw this situation in my practice, I just turned around and left the room. Somebody else needs to take care of this. So these are real life experiences from last summer. It's not an old stuff. I think it's really a call for help for healthcare professionals, how to deal with this not only spiritual dimension, but a holistic care. And so I have had the fortune to get like 2 hours allocated for spiritual care for our nursing students. And before they meet with me online in a small group from 4 to 10 people, I ask them to pick up a picture that represents their spirituality and write approximately 100 words about their spiritual belonging. So what they think or where they belong spiritually. And I have got lots of beautiful pictures of adventures, mountaintops, rainbows, lakes, sometimes also some family events. And once I got an empty room from a student, and this empty room caused me at least 1 month of thinking that what does it mean and why this empty room talks to me. And so I decided to do this kind of hermeneutical analysis of it. And you cannot, if you use text and picture, you cannot separate those. So that was the text what the student added. When I first saw the question that I should express my own spiritual belonging, I was overwhelmed. I have never perceived myself as a spiritual person. After all, I have nothing to do with the religion, or I have consciously turned away from it in recent years. And I also consider myself a very rational thinker, regardless. Hence, the image of an empty room as an expression of the emptiness in my head in relation to the subject. After examining the article and the definition of spirituality as a more than just religion, and a component of every personality, I'm thinking about my own spiritual orientation. The picture was taken before we moved into our flat. It represents the new beginning with thoughts that I will have about my own spirituality. So in this very short description, lots of things happen, and the hermeneutical thought is presented here. So looking at the picture and looking at the text, we saw that there are three aspects that are important for the student: the difficulty of articulating spirituality as a personal experience, so lack of the words how to describe this. But Margaret also said in her presentation, then the conscious distancing from religion, which was shown in our neurospirit study a little bit, as well as in the students' spirituality definitions. The self-image as a rationally thinking person, which excludes kind of the spirituality and religious dimension. So the student doesn't know what to do with the concept of spirituality as a personal experience. The result is the image of an empty room expressing the emptiness in her head. I have nothing to do with religion. I have consciously distanced myself from it is a statement in which the student says that she has nothing to do with religion, but at the same time it describes the respondent's past. So she has had something to do with the religion, like quite many of us have. Then it can be assumed that she has belonged to a religious community, so she actually masters the language. But this is obviously an assumption. Her current personal challenge is to consciously turn away from religion. The admission that I am a rational person defines the student's position in which she contrasts herself as a rational person with a metaphysically oriented person who might be interested in spirituality. The change in the subject's attitude takes place after the mandatory reading. So just a very short description of what spirituality is. And she has learned that spirituality is more than just religion, and that spirituality is part of every personality. An interpretation of spirituality that foregrounds personal experience enables the student who has nothing to do with religion to understand spirituality as a meaningful dimension of human life. The subject returns to the image, and the image that previously expressed emptiness is now a possibility. The text suggests that the image that previously represented emptiness in her head now represents the possibility of a new beginning associated with a newly acquired home. With the image taking on a new meaning, the student also formulates a goal. I shall begin to build my spiritual home. So if you come to this picture of an empty room, and this is also my last slide, I am obviously a researcher who works with text, and using pictures is kind of a new area for me. But when I have shown this picture to other colleagues, they have said, Berit, have you seen there is a door and there's a light coming into this room? So the self-assessment, even if it's a very brief self-assessment, we always tend to think of building spiritual curriculum, which is like 40 hours or 120 hours. I really want to put up a plaidoyer for this kind of very short self-reflective tasks, like take a picture, write about your spiritual belonging, and then maybe later look at this picture and try to talk with yourself about what does it mean for you, why you think you picked this picture of thousands of photos that are on your cell phone, for example. And this may really help to let the light into this empty room. And well, we have this famous citation that God said, "Let there be light," and there was light. So even without or with God, when we give students and healthcare professionals this kind of chance before they are expected to do any interventions, to understand the definition of spirituality and provide them with some self-reflective tools that can be used again and again, I think we also enable patients to receive better care also at the end of life. And that's it from me. Listening is learning. Thank you for listening.
Thank you, Perrette. Just right on time. If you just stop sharing the screen, maybe if Marg and Perrette can stay on screen as well. That's great. Look, we've got a few minutes for questions. And if anyone's, I have put something into the chat room. There's been a few comments going through the chat just on general people who've all, highlighted a couple of studies and things. But if anyone's got a question they'd like to ask, please do. I thought, Marg, I'd just like to ask you initially from my desk. We've focused on the study on end of life. It's the first study really that's focused primarily on end of life across the range of different illnesses. Is there anything particularly different that you've experienced or seen that hasn't come up in studies where they focused on PTSD or depression or other sort of depression and anxiety in other areas?
Yeah, that's a good question. I think chatting with colleagues overseas, I've really only been involved in 2 studies, this one and more recently a healthy volunteers study using a different psychedelic compound. But one of the things that we seem to think, and at the moment it's a hypothesis, but the transcendent aspects of the experience seem to be more accessible for people who are at end of life. They just seem to be more primed. They're already kind of thinking about existence and existential issues anyway. And they're at the point of life review. I think from a psychological perspective that they're really ready, that, the life review is kind of their starting point. With other issues, it may be that they're very kind of located in the here and now with their immediate, what's going on in their relationships and so forth. That's not to say it doesn't happen with our patients, and it certainly did, but they were hitting transcendent states very quickly. And this is just from anecdotal discussions with my supervisor, who was Dr. Tim Reed, who was a psychiatrist at Imperial College in London, who was a supervisor for the studies that happened for the treatment-resistant depression studies there. So, just seeing, I think, where people are at in terms of their preparedness, I guess, to go into some of those more existential issues, it seems to be more accessible to our patients. That's just a hypothesis. Yeah.
Thank you. We've got a question here for Perrette, and just asking about how is spirituality, say, expressed with children at the end of life?
I don't think that I am the correct person to answer this. That I have. It's an area for me that via self-reflection, I have understood that I could not work with children, and I couldn't face their end of lives. And this has been a self-reflection for very many years. So from the time where I did my PhD about cancer patients' experiences, then there were the children's stories, and I couldn't cope with that without supervision, I have to say. So it's a question of maturity, and I know that there is one person in Europe, at least, who works with children's spirituality, Alicia Damzak. I think she is from Zwolle in the Netherlands. But there are not very many people who deal with children's spirituality, and so it's a difficult area. But if you are interested in this, there will be a symposium on children's spirituality in May in Salzburg, so you're all welcome to join that.
Maybe Perrette will get somebody to put it up in the chat room as the connector there, but it's given us food for thought for next year. I know we're going to focus on children at some stage. So I just wonder as well, maybe both of you, but particularly Perrette, it sounds like from both discussions, in some ways, activity around this is there needs to be guidance. And that's not to say the person guiding is the expert, but there needs to be people to nurture and encourage whatever process they're going through, even if it's initially quite a negative kind of relationship with that experience. Did you want to sort of comment on that, both of you, about that nature of guidance or being a guide?
Yeah, maybe I start, because then you go to intervention. So it has been now many years we have looked at what leads to it, that spiritual care education is implemented also in clinical practice, and all evidence that is gathered so far points to the fact that you need this kind of mentors because you are meeting people and you make mistakes, and so you need a supervision and a mentor who you can follow, copy, make your mistakes, go back to this person and ask for guidance how to do the things better. So failing in a human, meeting human beings as a human is a natural thing. And so you need guidance and accompaniment in that. And I think that now, Margaret, you can.
I'll do my best. I couldn't agree more. I think, we do need a lot of, particularly I think in psychology and psychiatry, we are not good at talking about spirituality. And in fact, we've been encouraged to not talk about it, and to leave it to kind of tell people to speak with their priest or their imam or whatever kind of existential worldview that they happen to follow, and get them to speak to that kind of expert. That's not our domain, and it's been kind of taboo. And certainly, working in psychedelic assisted therapy and seeing the wisdom traditions and the lineages that it was informed by in Indigenous society. These are shamans that are very, very well practiced in these kind of spiritual and transcendent states. So we need supervision. This is very new for us in Western medicine, and we need guidance through that process. And I think one of the things that is really useful, I guess, about working with this in palliative care is that we do tend to very routinely ask about a person's cultural worldview and their spirituality, so we can sort of where do you locate yourself here, and help let them lead us a little too in terms of how they understand the world. They may be a Christian, but what type of Christian, or what is their spirituality? Has it changed? Has it shifted? Have they got a fractured relationship with it? But I think we're still learning the language around it. We're still learning to navigate it, I think, but yeah, we definitely need some more, again, and we'll need more supervision around it. Yeah.
Thank you, Mark. Look, that's most very rounding us to the hour. It has been a really interesting discussion. It feels like a discussion that we could have a lot more time and energy to, and one that we most very need to come back to at some stage in these forums. But really just to say thank you, and really just to remind people that there is more to the collaborative than the webinars, but we're stepping into 2024 with the first reporting back of work that's been done with the iLive project and the EU Horizon project. And I think John Ellershaw is leading that discussion at the next webinar. So stay tuned for 2024 in March. We have 4 webinars a year. You may also be interested, those of you who are travelling in Europe in May and would like to attend the summer school. So each year we hold a summer school in Malaga. And the 6th annual summer school will be there over the 13th and 14th, a couple of days before the EAPC research conference in Barcelona. So I think there'll be a few Australians tripping over there just for the occasion, including myself. And also just to remind you that our annual conference week or time together, which we've just had in Rotterdam in November in this year, but it'll actually be in Porto in Portugal in November next year. So a couple of things to put in your diary and look forward to. And in due course, more advertising will be going with that. Again, if you've enjoyed what you've seen today and it's your first time, the website is there in the web address. And also that if you do join, there's a certain number of things that you can access by members only, and you can either join as an individual or you can be part of a jurisdiction or an organisation, and that's explained as to depending on where you are in the globe. So again, a big thank you to Marg Ross and a big thank you to Perrette Paul. It's been a good evening, and we'll say good night for now from Australia, but have a good afternoon in the rest of Europe or wherever you are in the globe. So thank you. Thanks, everybody.
Thanks, everyone.
Great.